Hello and welcome to the third MACS training video. In this session, we will review how to abstract a case into Qualtrics. Starting at the MACS website, select your center's name under the data portals. You will be given a password specific to your center. Enter the password and click on Next. The first data to be abstracted will be patient identifiers. Notice that this will be where you enter the patient's MACS case number, which is generated by your MACS master spreadsheet. You will proceed through the next tabs by entering the patient's identifiers, demographics, arrival data, and risk factors. All of these variables are further defined in the data dictionary. You will then encounter the Disease tab and enter the primary and secondary ICD-10 codes. For the Readmission tab, if the patient has a previous MACS patient entry into Qualtrics, then select Yes. If this is the patient's first or index case as a MACS patient, you may leave No selected. You can use your MACS master spreadsheet to filter for the patient's name. If you selected Yes, this patient is a readmission, your next task will be to answer which disease bucket the patient was abstracted into during their index admission. The purpose of this is to associate a readmission case to a MACS index disease. Think of each index disease as a bucket that we use to connect any related readmissions. For example, if a patient had an emergent exploratory laparotomy during their initial admission and is later readmitted with a small bowel obstruction due to adhesions from that surgery, select exploratory laparotomy as the index disease. This is because the readmission is related to the previous surgery. If the readmission is completely unrelated to the prior index admission and the primary ICD-10 code for the new admission fits another MACS organ system disease, treat this as a new index disease. In this case, you would select the current reason for admission as the index disease. For instance, if a patient previously had an appendectomy and is now readmitted for acute gallbladder disease requiring a cholecystectomy, you would select gallbladder as the index disease. One way to keep track of this would be by adding an organ system column to your MACS master spreadsheet. When you have a readmission case and search the patient's name on your master list, you can quickly see what organ system they were sorted into previously. If your patient is a readmission and the index disease was appendix or gallbladder, an additional question will appear. For this demonstration, I will select appendix as the prior index disease. You will then be asked if the patient had an appendectomy prior to this readmission. This will allow for us to capture if the patient was medically managed for appendicitis at your hospital but had surgery at an outpatient surgery center or outside hospital, then had a readmission back to your hospital with a surgical complication. If you select gallbladder, then in the same fashion, you will be asked if the patient had a cholecystectomy performed prior to this hospital readmission. Next is the Disease tab. This is where you will enter the reason for emergent general surgery consult or admission. As stated in the data dictionary, the primary ICD-10 code will be the primary general surgery condition, and secondary ICD-10 code is a diagnosis not related to the general surgery problem, but pertinent to the patient's admission. In this training video, we will spend time going through each disease tab. Let's take a look at the Appendix tab. You will start by abstracting diagnostic imaging leading up to the diagnosis of appendicitis. If the CT scan confirms appendicitis, you will need to indicate the findings mentioned in the CT report. This includes abscess, cecum, or terminal ileum inflammation, fecalith, free air, free fluid, or phlegmon. If surgery was performed, enter the result from the pathology report. If the patient did not have surgery, select No Operation. Appendicitis type is determined by whether or not the appendix is perforated. Uncomplicated appendicitis means the appendix is not perforated. Complicated appendicitis includes cases where the appendix is perforated or there is appendiceal carcinoma. Complicated comorbidity refers to patients with non-perforated appendicitis who cannot have surgery due to other pre-existing medical conditions. If the patient is managed without surgery, select Yes for medical management. If the patient is managed with surgery, you will skip answering the questions regarding inpatient IV antibiotics. If the patient is managed medically, you will enter which class of IV antibiotics were administered and for how many days. Count partial calendar days as a full calendar day. collect data on up to 3 IV antibiotics. You will also add data on duration of oral or IV antibiotics prescribed at discharge. Next, we will discuss the gallbladder tab. The gallbladder disease cases also start by abstracting diagnostic imaging and procedures performed for the workup of the patient. Please note that studies labeled diagnosis in front indicate studies that are done before a cholecystectomy. If you scroll down, you'll find a section on secondary imaging and procedures. These refer to any diagnostic studies that are performed after the patient has had a cholecystectomy. So, if you're abstracting a readmission case for a patient who previously had a cholecystectomy, make sure to document any secondary studies under that readmission case entry. Now we will discuss the small bowel obstruction tab. For small bowel obstruction cases, start by collecting data on the patient's history, including any prior obstructions, abdominal surgeries, radiation treatments, or malignancies. You'll also need to gather information from diagnostic imaging. You will notice that there is quite a bit of clinical information to abstract from the CT scan read. The next question will ask whether or not a gastrografin challenge was given to the patient. Gastrografin is an oral contrast agent that can be used to try to relieve a bowel obstruction conservatively without surgery. If gastrografin is given and an X-ray shows contrast in the colon, this is called a positive colon result. If no contrast is seen in the colon, it's a negative colon result, indicating that the small bowel obstruction is still present. If the patient undergoes surgery for the small bowel obstruction, there is a specific section where you'll abstract the operative procedures and findings. This additional survey variable will appear in the Operation tab. The Exploratory Laparotomy tab. If the patient had an emergent exploratory laparotomy to manage a small bowel obstruction caused by volvulus, hernia, internal hernia, or mass or malignancy, please select Exploratory Laparotomy for the Disease tab, not small bowel. There is a more detailed explanation of this in the data dictionary. The Exploratory Laparotomy tab also begins with abstracting diagnostic imaging. If you select Yes to a CT scan, a drop-down box will appear, allowing you to record any additional findings. We also collect NEWS2 and SIRS data. NEWS2 stands for National Early Warning Score 2, a tool developed to standardize the assessment of acute illness severity. This section includes both vital sign data and results from the CBC and blood gases collected within 12 hours of surgery. You'll be documenting the worst set of values during that time frame. The data dictionary includes a link to a calculator that shows how to assign scores, where a higher score reflects a more severe patient condition. For the hypercapnic respiratory failure question, keep in mind, the blood gas must be an ABG, not a VBG. When abstracting blood gas data, if the patient has an ABG collected within 12 hours of surgery, you should select that over a VBG. If only a VBG was collected within that time frame, select venous for the blood gas type and enter the results. If multiple blood gases were collected, choose the worst results within the 12-hour window. If the patient only has a lactate result and no other blood gas values, enter the lactate but leave the blood gas type question blank. And finally, if no blood gases were collected, just leave all fields blank. For this section, begin by entering the date and time when the patient received their first IV antibiotic following the acute care surgery consult. Next, record the total number of ventilator days, as well as the dates the patient was admitted to and discharged from the ICU. If the patient had multiple ICU stays, use the admission associated with their exploratory laparotomy surgery. For the total ICU days, add up all the days from all of the ICU admissions and remember to count any part of a day as a full calendar day. We will now look at interventional radiology procedures. You'll see that we are only collecting information on certain interventional radiology procedures. If your patient only had a PICC line placed or underwent another procedure that isn't listed, choose No for interventional radiology. If one of the listed procedures was performed, select it from the list and enter the date and time it was done. The Operation tab. If your patient had surgery in the operating room, select Yes. You would also include patients who had bedside procedures in the ICU because they were too sick to go to the operating room. Enter the surgery date and time, as well as surgeon. You will also enter the ASA score, the type of operation, and whether the procedure was open, laparoscopic, or completed with the robot. Keep in mind, the AAST score is only required for appendectomy and cholecystectomy cases. This was covered in training video number 1. If you need the AAST scoring table, you can find it under the Resources section on the MACS website or in the Data Dictionary. To assign an AAST score to appendix or gallbladder cases, review both the operative report and the pathology report. This chart provides a summary of the scoring system. You can use the details on the AAST grading chart to help you choose the appropriate score, but remember, not every criterion in a row must be present to assign that grade. For example, Grade 1 covers acute inflammation. Grade 2 includes findings like necrosis or gangrene, and for gallbladder cases, it can also mean purulence or hydrops. Grade 3 is for perforation. Grade 4 applies if there is infection or other issues outside, but close to, the organ. Finally, Grade 5 is for infection away from the organ or cases of generalized peritonitis. If your patient has multiple procedures and CPT codes during the same surgery, you can enter Yes to input those additional CPT codes. You can also capture up to 8 CPT codes performed by your general surgeons on different dates during the hospital admission. If you are recording another CPT code from the same surgery, use the same date and time as surgery number 1 for surgery number 2. If the second surgery was performed on another day, enter that date and time. We will collect up to 8 CPT codes on a case. The intraoperative tab. If your patient had any type of bowel anastomosis, please enter the technique that was used. If an ostomy was created, enter the specific type of ostomy performed. Also, if the patient had any kind of hernia repair, select Yes. When you do this, an additional section will appear for you to enter more details about the hernia repair. The hernia tab. Input the hernia type, location and size, and whether or not mesh was used. If mesh was placed in a sublay position, please specify which sublay position was used. The Data Dictionary offers further information on this. Mesh type and brand options can be found in the appendix of the Data Dictionary. You will also need to enter the type of mesh fixation the surgeon used. Lastly, you will enter whether a myofascial release was performed during the hernia repair. The Occurrences tab. Occurrences should be documented for both operative and non-operative patients. However, some occurrences apply only to surgical patients. You can find these details within each variable's definition in the Data Dictionary. Remember, occurrences are tracked during the patient's hospital stay and for 30 days after discharge. For this question, if the patient did not have surgery, leave the blood transfusion field blank. If the patient did have surgery but did not receive any packed red blood cell transfusions, enter 0. A common bile duct injury means the common bile duct has been transected, which is a serious surgical complication. This type of injury always requires another surgery to repair the bile duct, either immediately during the same operation or in a separate, later procedure. For cystic duct leaks, we are tracking bile leak complications that can be treated with a stent during an ERCP procedure, or in some cases, these leaks may resolve on their own. Occurrences are listed in alphabetical order. Please review each occurrence definition within the Data Dictionary. Please note that the MACS definition for surgical site infection differs slightly from the MSQC definition. Also, if a patient qualifies for sepsis preoperatively, then you would only capture sepsis as a post-op occurrence if there is a new source or the patient meets criteria from the same source on post-op day 7 or later. This slide concludes the list of occurrences that we are capturing. All variables are defined in the Data Dictionary. If anything is unclear, please contact the MACS Program Coordinator. Opioids tab. If your patient was discharged with an opioid prescription, you'll need to document the details of that medication. First, select the specific opioid prescribed. For the strength, enter only the whole number representing the opioid component. Then, choose the correct units, record the maximum number of tablets allowed per dose, the maximum number of doses allowed per day, and the total quantity dispensed. For example, if a patient received a prescription for Norco 5-325 with instructions to take 5 to 10 milligrams as needed every 6 hours, and a total of 5 tablets dispensed, you would enter 5 in the strength field, select milligrams as the unit, 2 for the maximum tablets per dose, 4 for the maximum doses per day, and 5 as the total quantity. There are also fields to enter solutions or other forms of medication, such as patches or suppositories, if those were prescribed. Additionally, if the patient was given any opioids within 24 hours before discharge, make sure to mark yes for inpatient opioid use. A note on readmissions. If your patient is readmitted and is seen or treated by your general surgery team, you should enter a new case into MACS. Readmissions that are not related to the original admission, and cases where your surgery team was not involved, do not require a new case entry. For example, if a patient has surgery, is discharged, and then is readmitted within 30 days for a post-operative DVT needing treatment, you would record that DVT occurrence in the readmission case. If the same patient is discharged again and later readmitted for an anastomotic leak, you would record the leak in a new, separate readmission case. In this scenario, the patient would have 3 cases total, 1 original or index admission, and 2 readmissions. You should not enter a new readmission case if the patient is admitted for something unrelated to their original MACS entry and is not seen by your service. The Discharge tab. Enter the discharge date, time, and destination. If the patient goes to the emergency department or urgent care within 30 days after discharge, be sure to enter the date of that visit. We also track the date of death for all patients. This includes both operative patients and those who did not have surgery or were only seen as consults. Additionally, please enter the dates when the patient follows up with general surgery, as well as the date if they see their primary care provider within 30 days after discharge. Thank you for your time. If you have any questions, please reach out to the MACS Program Evaluation Specialist located on the MT-QIP website's contact list.